Hi, it's Dr. Centeno, and I was asked by a patient to put together a shorter, more succinct version of the Centeno classification of subfailure CCI and the different levels of procedures that are out there to address this. And so we're going to talk about, again, subfailure CCI, meaning no fractures, but stretched out ligaments. And we're going to talk about the different levels of injection procedures that match up. Now, this will go through my own classification system. It's more focused on which types of injections work the best for each of these problems. Obviously, from a surgical standpoint, there may be other classification systems. So let's get into CCI types. This is very important because unless you know which specific ligaments are injured and that are allowing craniocervical instability to happen, you can never focus treatment on that specific ligament. So we'll jump into types of CCI. And I've put this together in such a way to try to make it easy to remember. So a type 1 impacts the C0-C1. A type 2 instability impacts the C1-C2. And type 3 impacts C2-C3. So again, realize you've got the skull up here. That's called C0. And then below that, C1, C2, C3. Now, you can have more than one type of instability. For instance, we'll see a type 2B side-to-side 1-2 instability in a lot of patients that have a type 3 anterior-posterior, so a type 3A instability. And you're going to have mild, moderate, severe amounts of extra motion that may or may not correlate with the patient's symptoms. Now, before we get into these specific types, let's talk a little bit about injection procedure levels, because remember, we have to target the specific involved ligament if you're going to get better. And our ability to target that specific involved ligament gets better and better as I go from a level 1 procedure to 2 to 3 to 4 to 5. So right off the bat, blind injections without ultrasound or x-ray, what's called fluoroscopy guidance, should not be done at this point in time. So we're only going to be talking about image-guided injections. So for instance, what's called posterior treatment or posterior prolotherapy is this level 1. And that's just simply hitting the ligaments in the middle going down the spine, nuchal ligament, supraspinous, interspinous ligaments, and sometimes hitting what's called the posterior column. You're not getting into any of the joints in the neck. All you're doing is placing the needle in that general vicinity. A lot of simple prolotherapy clinics do this sort of level 1, where they use some guidance, but they're not really using guidance to get into a specific area or joint. They're just using guidance to place the stuff generally in that area. So this is sort of simple prolo. Now, since it's from the back or posterior, if you've got posterior ligaments, it might help you. Then we get into this level 2 procedure where we start to add in things like x-ray guided facet joint injections with contrast confirmation. Here, we're injecting directly into those joints, something like platelet-rich plasma, which might help an injured joint. In level 2, we're only doing C2 through C7. And then by the time we get to level 3, we're getting into those upper cervical facet joints. Now, that's rarefied air for 99.9% of the clinics that do these facet joint injections with things like PRP or other things like bone marrow concentrate. Why? Because they're extremely difficult to do. And so that's why it's level 3. We're going up a level in difficulty here. And then we get to level 4 procedures where we're doing all of that stuff. Plus we can get to the very front ligaments on the bottom part here, like the anterolongitudinal ligament, or the very deep ligaments in the back, like the posterior atlanto-occipital membrane. And then finally, we get to a level 5 procedure here, where we're doing all of the deep internal ligaments from the front. So that's that PICL procedure where we're treating alar, transverse, accessory, AAOM, AAOL, tectorial, cruciate, apical dens, AO ligaments, etc. Now again, off to the left, I could teach someone how to do this in a weekend. When it comes to level 2 procedures, it takes longer to learn, maybe a year. Level 3 procedures, you've got to be an advanced level 2 provider before you can do a level 3. And then level 4, level 5 on up. So before we get started, for instability in flexion and extension, we always inject the ligaments on the opposite side of the movement. So for instance, if we've got one bone going that way on the other, we're going to inject the ligaments on the other side. Now the only one that doesn't follow this rule is the alar ligament, and I'll get into that a little bit more as we get to that particular issue. So now that we know what those levels are, let's talk a little bit about the types of instability and where you need treatment. So this is a type 1A. Remember, type 1 was C0, C1 problems. And in this case, the skull is rotating too far forward in flexion. So that's going to be loose ligaments back here. And remember, it's always the ligament on the opposite side of the motion we want to treat. So here, since the skull is rotating too far this way, it's a ligament back here. And that's something you can treat with relatively simple level 1 injections, like a posterior prolo injection, not hard to do. Now you might need a level 3 injection to inject also that C0, C1 facet joint if it's injured, but you can start with just routine prolotherapy, and that's probably going to work. So here we're just going to do the same thing, but in extension. So here the clivoaxial angle increases as the skull rotates too far backwards. Now, here our lax ligaments are now in the front. So we can inject the posterior ligaments with posterior prolo all day long, and it's not going to do anything. In fact, we're going to need a level 5 procedure, PICL, to get these ligaments. And in these patients, you'll frequently see, as you can see off on the right there, that the very back of C1 tends to bang into the skull as they bring their head back on something like a digital motion X-ray. Now, for type 1C, this is a little different. Here we're getting sliding motion of the skull on C1. And that can either be due to damaged ligaments in the front or damaged ligaments in the back, again, opposite the motion. And it's often associated with this, a very shallow condyle. So rather than the occipital condyle from the skull fitting deeply into a joint at C1, or the C0, C1 facet joint, it's very shallow. And because it's very shallow, it allows this sliding motion to happen. Now, again, if it's sliding forward, then simple posterior prolo may help. If it's sliding backwards, not going to help at all. You're going to need to come in from the front in something like a level 5 PICL procedure. And if the 0-1 joint is really a little damaged from all this extra motion, you're going to need to inject that joint in a level 3 procedure, not something that a simple prolo clinic is going to be able to handle. Now we've got type 2, C1, C2 atlantoaxial instability, or type 2A. So this is where we've got loose ligaments now, but our main loose ligament is the transverse ligament right here. And the transverse ligament acts as like the seat belt for the dens. So that is causing an opening in what's called the ADI, atlantodental interspace. Basically that space between C1 and C2 up front. And you can also have some lax ligaments back here. So if you just had this problem, which is going to show up as an increased Grab Oaks or a dynamic BDI, Bayesian-Dens interval, then you can try some posterior prolo, but it's probably not going to work because the lax ligament is the strongest ligament in the body, and that's that transverse ligament. So that can only be reached as a level 5 procedure from the front during PICL. So again, lax transverse ligament, a type 2A. Now type 2B, now again, C1, C2, we have C1, C2 moving side to side. So this is the overhang. So C1 overhangs C2. And you see those corners not match up. So this is going to be overhang more than 3 or 4 millimeters when the person is bending their head to the side. Now that's due to a lax alar and accessory ligament. And again, you can try to do posterior prolo on these all day long. Maybe you'll get a little bit of response here and there, but it generally doesn't work because you're not getting this internal alar ligament. The only way to do that would be a level 5 PICL procedure from the front. Now, if you inject the C1, C2 facet, which is a level 3 procedure, you can get someone to feel a little bit better for a while because the facet joint's generally beat up, but you're not going to change this overhang motion without getting the alar accessory ligament directly injected, which is something like that level 5 PICL procedure. Then we've got the type 3s. This is all about C2-3 instability. So we have translation of 2 on 3. And I've added 2-3 into CCI because it produces symptoms that are very much like CCI symptoms. And so for this one, again, the good news is that you've got lax ligaments in the back here at C2-3. So you can treat those with a relatively easy, simple prolotherapy injection at 2-3, and it should work to tighten that up. Now, a type 3B goes the other direction. Now we've got C2 going backwards on C3 in extension. Now we got a problem, right? Our lax ligaments are in the front here, and there's just no way to get at them from the back. So if we're doing a posterior injection here, it's not going to work at all. And so you've got to do a level 4 procedure where you inject that anterior longitudinal ligament, and that ligament runs right on in here. And that's how you fix something like this or treat it. Then obviously we can have a C where it's doing both going forward and going backwards. Obviously need injections in the back and injections in the front. So to wrap this all up, there are subtypes of CCI, and this is an injection-focused subtyping system. But you have to treat the specific ligament that's damaged or stretched in order to get a result. And sometimes that's posterior prolo, sometimes that's much more sophisticated anterior prolo, sometimes that's injecting into the damaged joints, and there's many, many other types of customized injections that can be done here that I didn't go into to keep this simple. Injecting around irritated nerves, for example, etc. But you have to match the treatment to the ligament. And if you're not getting this level of detail when someone tells you you have CCI, you need to get this level of detail in order to get the right treatment. So thanks so much for watching and have a great day.